So, given the overlap, how do we structure our assessment? Number one, screening instruments. Use the McLean screening instrument for BPD or the MSI BPD and the mood disorder questionnaire or MDQ together when the presentation is ambiguous. Number two, timeline chart. Have the patient plot mood, sleep, energy, and triggers over the past month. Look for four or more discrete episodes in 7 days for the ultra rapid versus hour to day fluctuations tied to interpersonal events. Number three, collateral information. Gather input from family, partners, or case managers. They often notice cyclical patterns that the patient may miss. Number four, laboratory and imaging. Rule out medical mimics like thyroid dysfunction, substance use, or neurologic injury that can produce lability. And now, treatment. Treatment pathways diverge sharply, and getting it right early prevents harm. For BPD management, psychotherapy first. Dialectic behavioral therapy or DBT remains the gold standard. Mentalization-based therapy and chemotherapy are strong alternatives. Medication. Adjunctive, targeting comorbidities such as SSRIs for depression, low-dose atypical antipsychotics for severe dysphoria. Avoid high-dose mood stabilizers unless there's a clear bipolar comorbidity. Skill building with emphasis on distress tolerance, emotion regulation, and interpersonal effectiveness must be incorporated. For bipolar disorder, including ultra-rapid cycling and mixed episodes, mood stabilizers. Lithium, valproate, carbamazepine, or lamotrigine as first line. Choice are guided by episode polarity, renal, hepatic profile, and patient preference. Atypical antipsychotics are often added for mixed features like quetiapine, lurasidone, cariprazine, olanzapine. Adjunctive therapies like CBT, psychoeducation, and sleep hygiene, light therapy, may also be valuable, especially for rapid cyclers. For monitoring, frequent labs including lithium levels, metabolic panels, and close follow-up weekly initially to catch early signs of cycling escalation. Regardless of the diagnosis, lifestyle factors matter. For BPD, regular exercise, structured routines, and nutrition can buffer emotional volatility. For ultra-rapid cycling bipolar, consistent sleep-wake schedules, caffeine moderation, and stress reduction techniques like mindfulness or yoga are important because circadian disruption fuels cycling. Okay, now let's touch on ethical, legal, and liability touch points. Both conditions carry heightened suicide risk. So, documentation of risk assessments, safety plans, and informed consent for treatment, especially when prescribing off-label interventions, is a major consideration. Misdiagnosing BPD as bipolar and initiating aggressive mood stabilizer therapy can expose clinicians to liability if adverse effects arise without clear indication. Conversely, labeling a bipolar patient as BPD and withholding mood stabilizers may be seen as negligence. We remind you to clearly articulate diagnostic rationale in the chart, referencing DSM-5-TR criteria, and discuss uncertainties openly with patients and families. Let me share a quick case that illustrates the distinction. A 28-year-old woman presented with frequent emergency visits for feeling out of control. She described intense anger after her boyfriend fell asleep before she did. She was brought to the hospital following self-injurious behavior. Her mood normalized within a few hours once the relationship issue resolved. She started DBT, skills groups, and lamotrigine. 6 months later, her crisis dropped dramatically. Contrast that with a 32-year-old man who cycled through 4 distinct mood episodes in 10 days: 2 days of insomnia, racing thoughts, and grandiosity, followed by 3 days of profound hopelessness, weight loss, and suicidal ideation. No clear interpersonal trigger. Timeline chart revealed more than 4 episodes in a week, satisfying ultra rapid cycling criteria. He was initiated on lithium and quetiapine, added CBT for bipolar, and scheduled weekly labs. Within a month, his cycling slowed and he reported improved functioning. These snapshots underscore the importance of temporal mapping and trigger analysis. When in doubt, treat the safety first, then refine the diagnosis as data accumulate. Okay, that's a wrap for today. Hope you now have a clearer framework for distinguishing borderline personality disorder from bipolar disorder, including the tricky ultra-rapid cycling mixed presentation. We also have a toolbox of assessment and treatment strategies you can apply tomorrow. If you found this episode useful, share it with colleagues across disciplines. Until next time.